Right, today we are going to talk about Brown-Sequard syndrome. Brown-Sequard syndrome is a clinical situation which is produced by the hemisection of the spinal cord. Even though Brown-Sequard syndrome in a classical sense is not very common, right? But still it appears very frequently in exams. Why it appears in exams so frequently? Because to truly understand the Brown-Sequard syndrome, examiner is checking that do you know what are the tracks on one side of the spinal cord, what are ascending system, descending system, what is the position of the track, what is their function, and when those tracks are damaged or crushed or injured, what changes in the body appear, right? So let's start discussing from the normal structure of spinal cord very briefly, right? So what is the normal structure of spinal cord? We draw it here. I make our transection of the spinal cord, and here is your gray matter, spinal canal. This is, which is this part? Posterior horn, anterior horn, posterior horn and anterior horn, and there can be lateral depending upon the level of spinal cord section. And here is, okay, just a minute, yes. This is, yes, dorsal column. What is this? Dorsal column, and right and left. And here is your lateral column or funiculus, lateral funiculus, and here is anterior funiculus. And naturally here are anterior roots, right? And here are posterior root with dorsal root ganglion, right? Now, what really happens in Brown-Sequard syndrome, that there is damage to the half hemisection of the spinal cord or half of the spinal cord. Let's suppose damages in this area, right? Why such kind of damage should be there? Classical example is stab wound, right? Or there can be injury by a bullet injury, or there can be dart or kick or any type of fracture here in vertebral spine, which basically dislocated fracture damages half of the spinal cord. So when half of the spinal cord is damaged, the clinical situation is called Brown-Sequard syndrome. This is also called hemisection of the spinal cord, but complete hemisection is rare. Most of the patients who come to your clinical practice, they have a partial damage to the half of the spinal cord. So we can say Brown-Sequard syndrome can be complete Brown-Sequard syndrome when there is a complete hemisection of spinal cord, or it can be partial. What? Partial Brown-Sequard syndrome when there is a damage to one half side of the spinal cord, but not completely. Now, what will happen to the patient after this? Once half of the spinal cord is damaged. Let's start system by system, right? That we have a patient, and one system or second or third, when they're damaged, what happened? Let's suppose here is a draw person. This is cerebral cortex, midbrain, pons, medulla, and here is spinal cord. And let's suppose that, of course, this is the center of the spinal cord, anterior. What is this? Anterior spinal, anterior median fissure, right? Now, let's suppose that there's damage in the cervical cord, and this has damage, yes. Of course, there's no such clean-cut lesions, but we just think of that there's damage to spinal segment C5, 6, 7, 8, and T1. You know that this anterior rami from this area supply the brachial plexus, or they supply the upper limb. Let's suppose someone got bullet injury or stab wound here, right? And this part of the spinal cord has been crushed or damaged. Now, what will be the changes in patient's sensory and the motor system, right? For understanding that, let's start that normal, how in spinal cord system goes up. We talk about, first of all, dorsal column system, right? I will draw it here, dorsal column system. Now, let's suppose this is supplying the lower limb. This supply is coming from the lower limb, and here is, let's suppose it is upper limb. Now, in dorsal column, which sensations go? Actually, fine touch, yes, fine touch, vibration, proprioception, proprioception, which goes from the dorsal system. This is basically conscious proprioception. First of all, what is proprioception? What is proprioception? A sense of position, right? For example, with your closed eyes, you know which part of the body, which limb in the air is it in which position, right? So this is, the sensations are coming through a system which is called proprioception. Proprioception is, or we can say, the sensations which are coming from locomotor system, sensations which are coming classically from the muscles and from the joints and from the ligaments, tendons, right? Muscle spindles, they all comprise of the proprioception. Classical example of proprioception, I can tell you that your brain knows all the time what is the position of different parts of the body in the air all the time. Either you are consciously aware or not. For example, when you are walking, did you take your both legs off the ground sometime? Try to take both. When you are walking, your central nervous system understand which part of the leg is it in which position. If one is going to the ground, other is lifted up. Is that right? So all the sensations which are coming from the locomotor system, we call them proprioception. And there are two types of proprioceptions. Some part of the proprioception go to cerebral cortex. This is called conscious proprioception. For example, when a woman is doing catwalk, she is very much aware of her movements. Am I right? So that is conscious proprioception. Is that right? Then another part, a lot of proprioceptive information is going to the cerebellum, where automatic calculations are going on about the body part positions and tension in different muscles, tension in ligaments, and tension in the Golgi tendon organs, right? That is called unconscious proprioception. Now in dorsal column, conscious proprioception go, which determine the sense of position, right? When you are aware of your posture. Then not only fine touch goes by dorsal column system, sense of vibration goes, sense of proprioception goes. What else goes by dorsal column system? 2-point discrimination. Yes, 2-point discrimination. 2-point discrimination is actually very fine sense. When you stimulate, let's suppose on my hand, if you stimulate at 2 points, if I'm with the closed eyes and you stimulate with 2 pins, right? Of course, if there's significant distance between the pins, I will know that I'm being stimulated or touched at 2 points. But if you keep on bringing the 2 points of stimulation closer and closer, in the end, nervous system will perceive as one stimulation or one touch point, right? So ability of nervous system to differentiate that 2 points from the skin are touched very closely, but there are 2, not 1 point. This is called 2-point discrimination, right? This 2-point discrimination is very high on the lips, tongue. That is why so many sensations from this area, right? And also from the fingertips. And 2-point discrimination is very poor on the back. Is that right? As much you enjoyed kissing the lips, you don't enjoy kissing the back. Why? Yes, why? Sensations are less. Here, sensory nerve endings are very high concentration, highly dense. In the fingertips, highly dense. But in some other area, it is less. So what I'm saying, that fine touch or tactile stimulation can be perceived. And when there are 2 tactile stimulations very close to each other, but you still perceive them as 2 independent stimulations, we call it 2-point discrimination. Then another information which goes from the dorsal column, that is form perception. Let me tell you what is form perception. Please, you come here. Do your hand like this and close your eyes. And can you tell me what I have put in your hand?
This is a board eraser.
Okay, it is whiteboard eraser. Good. Keep your eyes closed. Can you tell me what is now?
Marker.
Marker. Now, how did he do? He was not only feeling the touch of the substance, right? He was feeling the touch, pressure, he could feel the form, texture. All this information is going by the dorsal column system. All this information is going by the dorsal column system. In central nervous system, in cerebral cortex, it is processed. And after the processing, he is able to recognize familiar objects or subjects? Familiar objects, right? What is put in his hand, right? So this is also dependent on dorsal column system. Is that right? Please sit. This is also called stereognosis. This sensation is also called stereognosis. So from the dorsal column, what are the sensation? Fine touch, 2-point discrimination, vibration, sense of position of proprioception and form perception. Now all these are going by the dorsal column. Is that right? Let me show how it goes. Let's suppose from the leg, these first order neurons come here, and from here first order neurons goes upward, and they are traveling upward, and they will end up into nuclei in the lower medulla. Is that right? Lower medulla. From the legs, this is fasciculus gracilis going, and this will end up into nucleus gracilis. From here, second order neurons will go to the opposite side, and they will go upward, and in the, what is this? Ventroposterolateral nucleus of thalamus. Ventroposterolateral nucleus of thalamus, and third order neuron eventually take the information to somatosensory cortex. Is that right? Now, you can see that this information ascended ipsilaterally within the spinal cord from dorsal root ganglion, right? The information which was supposed to go to the higher level, it was traveling ipsilaterally. This was from the lower part of the body. Let's suppose this is from upper limb, and this will also add first order neurons and second order neurons, and from here third order neuron. Now you see, actually from lower limb this is fasciculus gracilis going on, from upper limb this is, or upper part of the body, it is fasciculus cuneatus. Fasciculus cuneatus. Am I clear? And similarly, from the other side, information will come from the left side, and it will enter here, and it will, first order neuron ascend ipsilaterally, and here they will end up into the nuclei, and they will cross on the opposite side, and in the same way eventually they will reach, right? And this is from where? Upper part of the body, and this is also going in the same fashion and cross and reach upward. Now what we see, dorsal column system, this dorsal column system within the spinal cord is ascending ipsilaterally, and second order neuron, these are the nuclei. What is this nucleus? Nucleus gracilis. And what is this? Nucleus cuneatus, right? Gracilis, fasciculus gracilis from the graceful legs. From the graceful legs, right? So anyway, so these crossing is called internal arcuate fibers, and eventually reach here. Now you imagine, if you cut, let's suppose this damage on this side of the spinal cord, right? Here, in this diagram, now I can show that from the right side, this is the fasciculus, what is this? Gracilis, and what is here? Fasciculus cuneatus, and in the same way, gracilis and cuneatus, right? Now, actually, these are dorsal column system, and they are taking information from ipsilateral side. Right column is bringing information from the right side, and left column is taking information from the left side. Now, very simple thing. If you make a cut here, what will happen? It's very simple. What will happen, that if cut has been made here, then ipsilaterally these columns are taking information from the same side. Let's suppose my right hemisection is done here. If right side hemisection is done here, what will happen? The dorsal column system on the right side is cut, and right side, which fasciculus are cut? Fasciculus gracilis and fasciculus cuneatus, and then information coming from lower part of the body and upper part of the body going to the dorsal column cannot be taken to the central nervous system, and these patient will lose these sensations ipsilaterally. Is that right? Below the level of lesion, right? Come here on this diagram. So we can say, if this was the leg, not very romantic leg, but anyway, it is just a leg, and this is suppose arm, upper limbs, right? So you can look at here now. This was your dorsal column system going up. It is cut over here. And what is this? Dorsal column system on the opposite side. And here was the dorsal column system coming ipsilaterally, and dorsal column system coming on the other side. Now you can see one thing. They were supposed to cross from this side, and this which was coming here they were supposed to cross on this side. Now what you can see, when this part of the spinal cord at cervical level is crushed, right? This actually these sensations are lost from which limb? Not to the contralateral limb, but only to the ipsilateral limb, right? So what we say in Brown-Sequard syndrome or in the hemisection of the spinal cord, when dorsal column is damaged or it is cut or it is traumatized, then ipsilaterally below the level of lesion, here is the lesion, below the level of lesion, patient will lose which sensations? Dorsal column sensations. Dorsal column sensations. Now what are the dorsal column sensations? Patient will lose here touch, fine touch, vibration sense of position, 2-point discrimination, and form recognition. So if I'm the patient and if this part of the spinal cord is damaged, then for example right lower limb, there's loss of dorsal column sensations. Am I clear to everyone? Yes. This is one thing. In opposite limb, dorsal column sensations are intact. Is that right? Yes, what is your question?
Is the stereognosis same thing as form perception?
Yes, stereognosis and form perception is the same, right? Now let's come back. So this is one thing clear, right? Now we talk about another pathway, which is Spinothalamic pathway. Now Spinothalamic pathway is different than the dorsal column pathway. Spinothalamic tract, I'm going to show here by there are two spinothalamic tract which are taking information from the spinal cord to the thalamus. Spinothalamic tract, one is lateral and other is anterior, right? So here I draw the lateral spinothalamic tract. I will tell you exactly how it is formed and what it is doing. Here is lateral spinothalamic tract, and here is in this interior funiculus there is anterior spinothalamic tract. Now these are spinothalamic tract. First we'll see how they are formed, and then we'll see what they are doing, and then we'll see once they are injured what happened. Is that right? So let's see, we'll draw it here. Spinothalamic tract. Again, here is your what? Lower limb, and here are your upper limbs. Now, what you can see here, actually, first of all, I will show you the pain pathway, pain and temperature pathway. Pain and temperature pathway from lower limb, first order neurons are coming here, they enter dorsal root ganglion, they enter here and terminate. From the level of entry, second order neurons start and they cross to the opposite side. And from here this fiber will go upward, right? They will end up into thalamus, VPL nucleus, and go contralateral side. It means these pain fibers, pain and temperature fibers, which are ascending into what is this? Lateral spinothalamic tract, right? These pain and temperature fibers, they entered from here. Now it's from upper limb, right? And from here also they crossed and went up, right? So left side fibers will cross at the level of entry in the spinal cord. Wherever they enter in spinal cord, they slightly go obliquely upward. I will show you later, right? They go upward and cross and ascend on the contralateral side. In the same way, if we talk about the right lower limb, the pain and temperature fibers will come from here, right? They will enter, yes, and cross to the opposite side and then go upward. From upper limb, from the right side, now the fibers similarly come, they end up here and cross opposite side and go upward. Now what is the important thing to understand? That in lateral spinothalamic pathway, in lateral spinothalamic pathway, pain and temperature information is modalities are taken up. But pain and temperature fibers, again I'm repeating, at the point of entry, right? What happened? The fibers cross contralaterally. So they ascend contralaterally. Is that right? So pain and temperature from the right lower limb will enter in spinal cord and ascend which part of the spinal cord? Left side of spinal cord. And in the same way, pain and temperature from left side of the body will enter in the spinal cord, but they cross over at the level of entry or 1 or 2 segment up, and then they will ascend on the right side. So it is very important thing that dorsal column modalities, they came, enter into spinal cord and they ascended upward ipsilaterally. Dorsal column modalities, dorsal column sensations enter into spinal cord and they did not cross over, they ascend ipsilaterally. But pain and temperature sensations, when they enter into spinal cord, they cross over and ascend contralaterally. This is very important point to understand. Is that right? This is one thing. Secondly, there is crude touch. I told you dorsal column sensation was taking which sensations? Fine touch. Fine touch you can feel with the pin. And crude touch can be, patient can perceive it by the cotton ball you touch, right? Crude touch sensations come from one limb, enter into spinal cord, and they also go contralaterally but anterior funiculus. Where in anterior? Yes, funiculus. So it means crude touch fibers, right? They also, when they enter, they cross over at the level of entry, but they ascend upward through interior funiculus, right? Don't call it gross touch. It is not gross touch, it is crude touch. If you tell a woman about gross touch, she will not be very happy. So talk about crude touch. It is taken from which fiber? Anterior spinothalamic. Now come here. So this was your, what was this? Lateral spinothalamic, and this was anterior spinothalamic. Lateral were taking which sensations? Pain and temperature. And anterior was taking crude touch. Now you have seen that this is called spinothalamic system. Anterior and lateral together they are just called spinothalamic system. So we can say spinothalamic system can take pain and temperature and crude touch. Is that right? And spinothalamic fibers which are going upward, they are taking information from the contralateral side as information entered and crossed over. Clear? Now we come over here in this diagram. In this patient, let's suppose this is spinothalamic information coming. What is this information coming? Spinothalamic. Now it will cross from here and then go upward contralaterally. And pain and temperature and crude touch entered from the lower limb from here, and again it crossed and then went contralaterally upward. Now you can see in Brown-Sequard syndrome what will happen. When dorsal column are traumatized, there is loss of, below the level of Leon, look at this, below the level of Leon, dorsal column sensations are lost ipsilaterally. But pain and temperature sensations or spinothalamic sensations, or we can say pain and temperature and crude touch sensations, crude touch along with tickle and itch. Spinothalamic system, classically we can say it takes pain, temperature and crude touch. Okay. But if you really want to be more additions, you can say spinothalamic system takes not only pain, temperature and crude touch, but it also takes the itching sensations of itch and also tickling sensations, right? Okay, now come back here. So when there is there is lesion on half of spinal cord, hemisection on the right side, right, and right spinothalamic system is damaged. This is right spinothalamic system is ascending fibers are damaged here. But these fibers are originally coming from the opposite side. So pain and temperature sense along with the crude touch will be lost in contralateral side. Below the level of lesion, pain, temperature and crude touch will be lost on contralateral side. Am I clear? Yes. Now, let's talk about, here is the lesion and what happened below the lesion in sensations only. I'm going to talk about only sensory system, right? Again, ipsilaterally, what were these fibers? Dorsal column system. Dorsal column medial lemniscal system, right? Now dorsal column sensations, they are lost ipsilaterally, right? On other side, from right limb, lesion is on right side. Right limb you lose dorsal column sensation. In left limb, dorsal column sensations will be intact. Why? Because from the left limb, sensations are going ipsilaterally and they escape the lesion because they are on the other side. They escape the lesion. So this will be a very strange situation. In my right lower limb, I cannot feel fine touch, I cannot feel the vibrations, I cannot feel the sense of position, right? And I cannot feel the 2-point discrimination of form perceptions, fine modalities, the dorsal column modalities. But dorsal column modalities on the left side will be intact because both came and went ipsilaterally. Here on the right side it is damaged, but left side it escaped the lesion. But when we talk about pain and temperature and crude touch, tickling and itching, these are going through spinothalamic tract. At the point of entry, they cross over. So right sensations go to the left side and left spinothalamic sensation come to the right side. Left come to the right side. And when they are ascending upward, if lesion is here, so what will happen? Sensations, spinothalamic sensations from lateral spinothalamic tract and anterior spinothalamic tract, when they are cut on the right side, sensations are lost on the left side. So left limb will lose pain and temperature, crude touch, itching, tickling, things like that, uncrude, right? Opposite to that, in the right limb, pain and temperature fibers have escaped on the opposite side. So escape the lesion. Crude touch will also escape the lesion. So in the right limb, ipsilaterally, what sensations will be intact? Pain and temperature will be intact. Gross touch, no, crude touch will be intact, right? Is it clear? Now, I want to just make a little test from you. Now be alert. Okay, I have a injury on cervical cord, hemisection on the right side. Right? Dorsal column sensations will be lost on which side? Below the lesion where? Below the lesion, right side. And pain and temperature sensation and crude touch below the lesion will be lost? Left side. Very good. And if I have lesion on the left side, then dorsal column sensations are lost on the left. Very good. Left lower limb. And if lesion is on the left side, then pain and temperature are lost on the right side. Clear? This is one way to look. Another way to look at this, that let's suppose I'm the patient, hemisection of the right spinal cord at cervical level. Hemisection of right. Now, what are the findings in the right limb? Sensory findings. And what are the findings on the left limb? I will say, if right lesion is there, first of all, dorsal column sensations on the right side are lost, but pain and temperature and crude touch on right side are intact. On left side, in this patient, on the left side, dorsal column sensations are intact, and pain and temperature sensations and crude touches lost. Am I clear? There is no problem, right? Now, look at the level of lesion. I'm just dealing with the sensory system now, right? Level of lesion, what happened? Below the level of lesion we have seen. What happens at the level of lesion? At the level of the lesion, what was these fibers entering? What were these? Dorsal column. And here was pain and temperature, which was supposed to go to the opposite side. But actually, at the level of lesion, whatever sensations were entering here, they are crushed. So, at the level of lesion, not only dorsal column sensations are lost, but spinothalamic sensations are also lost. Is that right? Let me tell you that at the level of lesion, I will make it a more clear diagram for you. Okay, I'm just making a very simple diagram. This is the dorsal column system going. Yes. Ipsilaterally, dorsal column system going. Ipsilaterally. Am I clear? This is spinothalamic system which crossed and went contralaterally. And from here, spinothalamic system crossed and went contralaterally. Is it clear? Yes. Is that right? Now, lateral cortical. Now, in this area, suppose this is lower limb, upper limb. Here were dorsal root ganglion. Now, this point you need to understand. These were two dorsal column sensations coming, right? And they were supposed to go to the same side here. Is that right? And these are your pain and temperature sensations, which are supposed to cross over to the opposite side. But actually, because there is damage here, what will happen? All the sensations which are entering here, all the sensations which are entering at the level of the lesion, they are damaged. So at the level of lesion, patient will have what problem? Complete loss of sensations. Dorsal column sensations are lost, as well as pain and temperature sensations are lost. Now, we come back. If I'm that patient and cervical lesion is there, C5 to T1. Now what will happen? All the sensations which are coming from my upper limb, dorsal column sensations as well as pain, temperature and crude touch, at the point of entry, they are damaged. So will I have any sensations in upper limb? No. So at the level of lesion, there will be complete anesthesia ipsilaterally. There will be complete cutaneous anesthesia ipsilaterally. Am I clear? So in this patient, what we have learned, the right hemisection at cervical level. Now only we are talking about sensory system. At the level of lesion, there is complete anesthesia. Below the level of lesion, ipsilaterally, dorsal column sensation lost, right? And below the level of lesion, contralaterally, pain and temperature and crude touch lost. Any question? It's clear? Thank God. Now we come to another thing. There is another system which is concerned with the unconscious proprioception, and that system is called spinocerebellar system, right? Let's talk about that. Spinocerebellar system. Now, if we talk about spinocerebellar system, let me make a diagram here. Let's suppose here is your brainstem, midbrain, pons, medulla, and here I enlarge. Okay, and here is your. Now here is your cerebellum. What is it? Cerebellum. And here are your cerebral peduncle. Superior cerebral peduncle, yes. Middle cerebral peduncle, and inferior cerebral peduncle. Is that right? Now, how the sensations go from the spinocerebellum, from spinal cord, sensations go to the cerebellum also. Actually, there are two pathways here. Behind here is dorsal spinocerebellar, and here it is anterior spinocerebellar. Here it is, yes, dorsal spinocerebellar, and here it is anterior spinocerebellar, right? Now, how the sensations go? These sensations are again proprioceptive sensations, right, which are coming from the locomotor system, but they are unconscious proprioception. Remember, through dorsal column, the proprioception which was going upward, that was conscious proprioception. But in spinocerebellar system, proprioceptive information going to the cerebellum is unconscious proprioception. Now, fibers come here. This is dorsal spinocerebellar tract. Here fibers enter, right? Fibers enter, and from here, second order neurons start, which go ipsilaterally. They go ipsilaterally, and from here they will go upward, and through the, what was it, inferior cerebellar peduncle, fiber will go to the cerebellum. It means the unconscious proprioception which is going upward through dorsal or posterior spinocerebellar tract, that is going ipsilaterally. That is going ipsilaterally. Even from this side I can bring. So this is going for, what is this? From here, dorsal column, right? Dorsal, and these fibers will also go upward, but they will go ipsilaterally. Am I clear? And now, if in the transection, if this is damaged, dorsal spinocerebellar tract, then it means unconscious proprioception from ipsilateral side, which was going to cerebellum, is lost. Is that right? Now, this unconscious proprioception, which was going upward ipsilaterally through the dorsal spinocerebellar tract, it was concerned with the movement coordination. When we are making movements, the coordination of different movements, that coordination work is done by cerebellum, and information is going to cerebellum. Here I have shown dorsal spinocerebellar tract. Now, if this is damaged, if this tract is damaged, look here, then from where we lose the information? Ipsilateral information is lost or contralateral information is lost? Ipsilateral. So on the below the level of lesion, this is below the level of lesion, ipsilaterally we lose the sensations, unconscious proprioception, which were going to cerebellum. So cerebellum become blind to the position of the limb or body on ipsilateral side below the level of lesion. So it cannot coordinate the movement on the right side. And incoordinated movement, if they are produced on the right side, we call them dystexia. What we call them? Dystexia. So we can say, during the hemisection of the spinal cord, when there is damage to the posterior or dorsal spinocerebellar tract, then ipsilateral dystexia is produced. Am I clear? Yes. No question. Now we come to anterior. What is this? Spinocerebellar tract. Interior spinocerebellar tract fibers are very naughty fiber. There are a lot of twists they make. They are not as simple. They enter like dorsal column and go upward and go on the same side as cerebellum. No. These fibers, let me show you, these are fibers which are going for anterior. These fibers enter. After the entry, they go contralateral. And from here, they go upward. Where they have gone? Superior cerebellar peduncle, and from there within the cerebellum they cross back. Within the cerebellum they cross back. Now you see, these fibers, information started from the right side, but it ascended on the left side, but again crossed back and came to the right cerebellum. It's a little twisty thing. You can say this is a double cross. How double cross? First cross at the level of entry, then ascend on the opposite side, then second cross within the cerebellum. In the same way, the sensations which are coming from the left side, now you can understand, they will go for which? Anterior spinocerebellar tract. Coming from the left, they should go to the right. And then through the right, they go upward. And what is this? Superior cerebellar peduncle, and then come on this side. Now, it has a clinical implication. What is the clinical implication? If injury is on the right spinal cord, right side of spinal cord, hemisection on the right side, then dorsal, what is this? Dorsal spinocerebellar tract as well as ventral spinocerebellar tract, both are damaged. Both are damaged. But dorsal was taking information from the ipsilateral and ventral was taking information from the contralateral limb. The damage to the dorsal tract, Which tract? Spinocerebellar. Damage to the dorsal tract will produce dystaxia on the ipsilateral limb below the level of lesion, but damage to the ventral tract will produce dystaxia in contralateral limb. Is that right? So now we have added one more thing, that in this patient where there was cervical spinal cord hemisection, what will happen? Patient is having, yes, dystaxia problem. Patient will have dystaxia in the right lower limb due to damage to the posterior spinocerebellar tract, and may have dystaxia on the left side due to anterior spinocerebellar tract. Am I clear? So patient will have double dystaxia. But remember one thing, these patients have very severe dystaxia. You know why? The reason being, conscious proprioception is lost below the level of lesion. Conscious proprioception is lost due to dorsal column damage, and unconscious proprioception is also lost due to the spinocerebellar system, and double loss of sensations, right, or proprioception, conscious and unconscious, produces severe dystaxia in the ipsilateral side. Am I clear? Any question up to this?
Are they both related with anterior and posterior? Are they both related with the dystaxia?
Yeah, actually listen, spinocerebellar system is taking information from lower limb and upper limb to the cerebellum, and this information is taken to the cerebellum to inform the cerebellum about the position of upper limb and lower limb, and also inform the cerebellum about the tension in the muscles, tension in the ligaments, tendons and joint capsules, and cerebellum compute all that information, right, and that computation, it determines what is the position of a specific part of a limb in the space, and if it is moving, in which direction it is moving, what is the rate of change of information which is coming from the proprioceptive system, and even it can calculate in the future that if movement continues, for example tension keep on increasing with the same velocity in the muscle and Golgi tendon organ, what will be the position of the limb in few milliseconds. Is that right? Now what happens, by this information cerebellum is able to coordinate. You come over here, I will do a little experiment with you. Stand here, close your eyes. Now about his body position, he does not have visual information, but do you know where is your right hand? It is up or down?
Up.
Okay, now it's up or down?
Down.
Okay, and now
It's upward.
okay, he didn't look at it. Cerebellum is computing information from muscle stress, length, tension in the muscles, Golgi tendon organs, capsules and the ligaments, right? Okay, now I will do another thing. Close your eyes. Can you, with the right finger, index finger, can you touch your nose tip? Okay, it means when he was moving, he was knowing where is his finger. He moved from there. He was also knowing where is his nose. Now take it slowly there. Now on the way cerebellum is calculating it is in right direction or not. And now it will reach. He didn't look at, visual information was not there. It means cerebellum is receiving the, what is this? All information. Now do one thing. I put this finger in the air, bring the other hand and same finger, okay, thumb of this is right hand thumb. Touch the left thumb to the right thumb. How could he do? Okay, I am separating it, you again touch them rapidly. Now cerebellum was telling what was the position, initial positions of both thumbs. Cerebellum was calculating, and then when it was moving, cerebellum was calculating the velocity. Now do it very rapidly with closed eyes. Now he miscorrected, then he will correct. Cerebellum, actually when he did fast, he went wrong. Then cerebellum suddenly detected position is not the desired, then it corrected it. So cerebellum does the function of coordination. Thank God for cerebellum. When you are walking, you don't take your both legs by chance, by mistake off the ground. Is that right? Your cerebellum knows which part of the body in the space is how oriented. Thank you. Please. Right, so let's come back. So what happens when dorsal, what is this? Spinocerebellar tract is damaged, ipsilateral incoordination of the movements occur. So ipsilateral dystaxia below the level of lesion. And when ventral spinocerebellar tract is damaged, it was taking information from contralateral side. So contralateral dystexia or incoordination of movement below the level of the lesion. Yes, you have a question.
Yes, sir. I have that infection overshoot. So mistakenly infection of overshoot, then basically can resist it or not?
Okay, listen. You come here, you will see. Come here. He is saying that if it overshoot, can it resist or not? Come here rapidly. Rapidly, my friend. It's okay, your dress is beautiful. Don't worry, don't worry. Just cover a little, yes. Okay, now listen. Do one thing, just I'm doing. With closed eyes, you bring your index finger rapidly tip to tip. Very rapidly. Okay, very good. Now, just a minute. Yes. Close your eyes because I don't want visual. Do it as fast as possible. You don't mistake and then correct it. What happened? That computation could not go so fast and actually he made a mistake. But cerebellum came to know, oh, desired position was this and it is not at desired position, it corrected. But if you go slowly, now you go slowly, you will not make a mistake. No, more slowly. I hope your cerebellum is not drunk. Slowly, very slowly. Yes, now it is. I think your cerebellum is undergoing some emotional, please have a seat. Okay. Yes.
So will there be any dysdiad of kinesia?
Yes.
Will there be any dysdiad of kinesia?
Yes, there will be. All features of cerebral dysfunction will be there. But remember, dystexia or ataxia can be sensory ataxia, which is due to failure of sensory information going to cerebellum. Or dystexia or ataxia may be due to primary lesion of the cerebellum. That information is coming, but it cannot compute. That is called cerebral dystexia. Is that right? And it may be due to, let's suppose, vestibular system, because information come through dorsal column system to cerebellum, then also come from spinocerebellar system, right? If these systems are damaged, we call it sensory dystexia. If cerebellum itself is damaged, then we call it cerebral dystexia. And if vestibular system, which also tell about the kinetic movements and also about the balance, if vestibular system is damaged and cerebellum cannot get enough information or correct information and patient develop incoordination of movement, we call it vestibular dystexia. Is that right? In hemisection of spinal cord, what kind of dystexia can be seen? Sensory dystexia. Am I clear? So these were sensory lesions. I will sum up the sensory lesions. First of all, we'll see what happened at the level of lesion, and then we see what happened below the level of lesion. I'm talking about only sensory findings. At the level of lesion, yes, dorsal column sensations, lost. Pain, temperature and sensations, lost. Spinocerebellar unconscious proprioception, lost. So actually we can say at the level of lesion, all the sensations which are coming at the level of lesion are lost. Is that right? Now below the level of lesion, that is the important understanding. What sensations are coming ipsilaterally? Dorsal column sensation lost ipsilaterally, and spinothalamic sensation lost contralaterally. Dorsal column sensations were what? Fine touch, vibration, 2-point discrimination, sense of position or conscious proprioception, and stereognosis or form perception. All these are classically, you should remember at least 3 dorsal column sensations. Minimum you should remember. Fine touch, vibration and position. These are lost ipsilaterally, right? But ipsilateral limb has pain and temperature sensations intact and crude touch intact, because those sensations entered and crossed over and escaped the lesion. Now below the level of lesion, contralateral side, which sensations are lost? Spinothalamic sensation, that is anterolateral system sensations. What are those sensations? Pain, temperature and crude touch. Is that right? But on contralateral side, dorsal column sensations are intact. Am I clear? Right? So in this patient, upper limb all sensation lost, ipsilaterally lower limb dorsal column sensation lost, contralaterally lower limb pain, temperature and crude touch lost. Is that right? Now another thing. Sensations which are lost contralaterally, they are 1 or 2 point segments below the level of lesion. Let me explain it, how it happens. Just a minute. This is the middle, right? These were the sensations which were going. Yes, what were these sensations? dorsal column sensations which go what? Ipsilaterally, right? Is it clear? And here is our, what is this? This is our lesion. Is that right? Okay. Pain and temperature sensation. Now look, at the point of entry, they actually obliquely go and then go upward. Is that right? So at every point of entry, they go obliquely. In the same way here, the sensations which are coming, they are after entry, at the point of entry, they become oblique. One or two segments they ascend and then go upward. Is that right? Now look at here. At the level of lesion, at this point, pain temperature lost, dorsal column lost. But opposite side, here pain and temperature, which was crossing, that is lost. Is that right? But at the level of lesion, exactly opposite side, it will come and it will cross and may be spared. This is the point to understand. At the level of lesion, pain and temperature and crude touch, when they entered, they became oblique and they might escape the lesion and then they cross upward. So due to this reason, what really happens in the patient, the contralateral side loses pain and temperature one or two segments below the lesion. Because fibers which are entering at the level of lesion obliquely cross. If they are going straight, then they will be also damaged. Am I clear to everyone? So if I make a diagram like this is a beautiful man and I'm talking about sensory losses. Yes, for example, lesion is here, right? And here was your beautiful, I'm making a very large spinal cord. This was the center, right? At the level of lesion, everything lost. Dorsal column sensation as well as spinothalamic sensation. Below the level of lesion, ipsilaterally, which sensations are lost? Dorsal column, right? But pain and temperature ipsilaterally escape. Is that right? Then dorsal column sensation on the opposite side are intact, right? But pain and temperature sensations from the opposite side, they cross and they are caught. Is that right? And at the level of lesion, everything is lost, but pain and temperature loss on the opposite side because fibers do a little oblique. Everywhere they do little oblique entry. After entry, they become oblique. So damage is 1 to 2, loss of sensation, pain and temperature is 1 or 2 segment or 3 segment below the lesion. Is that right? Now we make this man more simple way. Now you will tell me. What sensations are lost below the lesion? Dorsal column sensations. Lesion is on right side, left side is okay. Okay. Then what sensations are lost here? Pain and temperature. But pain and temperature is lost up to this level, right? But this dorsal column sensations are lost up to the level of lesion plus in the level of lesion also. And at the level of lesion, pain and temperature ipsilaterally is also lost. So what is the important point? We have already discussed it so many times. At the level of lesion, all sensations lost, complete anesthesia, ipsilaterally. Below the level of lesion, ipsilaterally dorsal column sensation lost. Below the level of lesion, contralaterally, pain, temperature, crude touch lost, but 1 or 2 segment below the lesion. And due to failure of dorsal spinocerebellar tract, which goes ipsilaterally upward, dorsal spinocerebellar tract, there is dystaxia on the right side. And due to ventral, here also ventral what? Spinocerebellar tract is damaged. So there is dystaxia on the opposite side. So this was about the sensory damages or sensory findings in a patient with classical hemisection of spinal cord, right? After a break, we will discuss about the motor finding. Right, so now we are discussing the second part of Brown-Sequard syndrome. In previously part, what we discussed, that when hemisection of spinal cord is done, what will be the sensory pattern of sensory losses in the body. In this part, I will discuss what will be the pattern of motor losses after the hemisection of spinal cord. A very brief introduction to upper and lower motor neurons, right? Let's suppose here is your central nervous system and midbrain, pons, medulla, and here is your spinal cord. Here is your upper limb and here is your beautiful lower limb, okay? And of course, suppose there's a muscle in the upper limb on both sides and there are muscles in the lower limb on both sides, right? Now, lower motor neurons are those neurons which start from the spinal cord or motor nuclei of brainstem and directly innervate the at neuromuscular junction. So these are lower motor neurons. Is that right? Now, upper motor neurons, the most important are corticospinal pathways, which are pyramidal pathways as well. There are other upper motor neurons also, which I will not discuss now. Other upper motor neurons like vestibulospinal pathway or rubrospinal pathway or reticulospinal pathway or olivospinal pathway, tectospinal pathway, we will not discuss them. Right now we will only discuss about the corticospinal pathway, which is one of the most important upper motor neurons. Now, corticospinal fibers, which they basically make crossing at lower medulla, right? And they are originating from cerebral cortex, right? Now look at it. From the cerebral cortex, corticospinal fiber descend through the corona radiata and pass through the internal capsule, then through the brainstem, and in lower part of the medulla they make a crossing. And then after the crossing, they will descend ipsilaterally and innervate the lower motor neurons. Is that right? In the same way, these fibers which have done the crossing, they are also moderating the behavior of lower motor neuron. Am I clear? Now, when there is section of the spinal cord here, let's suppose, now look here very carefully. These red neurons are lower motor neurons and green neurons are upper motor neurons. Let's suppose here was your lesion, cervical cord. Now what will happen? At the level of lesion, ipsilaterally lower motor neurons are lost. At the level of lesion, ipsilaterally lower motor neurons are lost. And when these lower motor neurons are lost, it means that if the lesion was from C5, 6, 7, 8, T1, so it means the lower motor neurons which were going to the brachial plexus or innervating the muscles of the upper limb, they have lost their action, right? So the clinical manifestation of motor system assessment, if you do the motor system assessment on this upper limb, there will be manifestation of lower motor neuron type of lesion. What kind of lesion will be here? Lower motor neuron type of lesion. Type of lesion. I will discuss that later. But simply you just see lower motor neuron is lost. But below the level of lesion, ipsilaterally, do you think lower motor neuron to the lower limb are damaged? No. Below the level of lesion, lower motor neurons keep on supplying their muscles. What is the real loss? The real loss is that lower motor neuron below the lesion have lost their upper motor neuron control. You see, this was the upper motor neuron which was coming from here and it was destined to, or it was going to regulate the lower motor neuron in lower limb. But while it was passing through the lesion, it has been damaged. This has been damaged. So what is the real motor problem below the level of lesion? The real problem is not the loss of lower motor neuron. Lower motor neurons are there. The real loss is the loss of influence of upper motor neuron on the lower motor neuron. Is that right? And now lower motor neurons behave abnormally. Just imagine upper motor neurons are like controlling fathers. Controlling fathers. Lower motor neurons are naughty sons. Lower motor neurons are the naughty sons. So when the father dies, when the upper motor neuron dies, initially lower motor neurons undergo spinal shock. When father dies, for few days, sons will be depressed. The naughty sons will be depressed, underactive. But after some time, due to the loss of controlling influence of the dad, because there's no control, they start hyper-functioning and maybe starting disturbing the family and the community and many other things I don't want to mention. Is that right? Same thing happened here. Here, unfortunately, here lower motor neuron died, sons died. And here sons are intact in this part of the community, but fatherly control is lost. So after initial spinal shock, in which lower motor neurons are underworking, they gradually recover. And then they start hyper-functioning. And special type of clinical features develop in this area, right? In which lower motor neurons are functioning abnormally because of the loss of upper motor neuron influence. We call that this part of the body or this part of the motor system in the body is displaying what kind of lesion? Upper, okay, it should be green. Upper motor neuron type findings or lesions. Or we can say, now again I will repeat, at the level of lesion, upper and lower both are damaged, but manifestation is there is no control on the muscle by lower motor neuron. So we say that lower motor neuron syndrome is there. In upper limb, what will be there in this patient? Lower motor neuron syndrome, because lower motor neuron coming out has been crushed. In lower limb, lower motor neuron are intact. There is actually loss of influence of upper motor neuron. So clinical manifestations which develop here, they are upper motor neuron type. Here the sons are dead. Here father is dead and son after initial shock and grief, they recovered and then they become hyper. Am I clear? Now, so in this patient with hemisection of spinal cord, the motor findings at the level of lesion will be lower motor neuron type. Below the level of lesion, motor abnormalities will be of upper motor neuron loss type. Now, what are classical features of lower motor neuron damages? Number one, there is severe loss of mass of muscle. Is that right? There is severe loss of power, right? And then there is severe loss of tone. So what happened that this patient has in upper limb, there is severe loss of mass, severe loss of power, and there is severe loss of tone. So upper limb will become flaccid, hypotonia, flaccid. We also call it flaccid paralysis. What do we call it? Flaccid paralysis. Right? And of course, because all the sensations entering here are lost as well as lower motor neurons are not there, so there is areflexia. Areflexia, which reflexes in the upper limb will be lost. Along with that, the muscle, when they do not have the control by the lower motor neuron, right, they become oversensitive to acetylcholine and they become overall oversensitive. Even with little tapping, they show fasciculations, localized contractions, and they may have fasciculations. Fasciculations are localized contractions in the muscles which have lost lower motor neuron control, right? So fasciculation, and if you look at microscopic level, we call it fibrillations. Now, again, at the level of lesion, right? What is the real damage? Okay, let me show you. At the level of lesion in the spinal cord, here was lower motor neurons which were coming out, anterior horn. Maybe this root is damaged, or of course this anterior grey horn is damaged. When anterior grey horn is damaged and even ventral root may be damaged, of course that will result into lower motor neuron loss to the muscles involved. Lower motor neuron syndrome, there is severe loss of mass, loss of power, especially in specific muscles, severe tone loss, reflexes are lost, deep tendon reflexes are lost, and fasciculations should be there. All this together is called lower motor neuron syndrome. Is that right? And lower motor neuron syndrome will be seen in upper limb. At the level of lesion, you will see lower motor neuron syndrome, and below the level of lesion, you will see upper motor neuron syndrome. Is that right? Any question up to this? But yes.
Sir, is there tremor and fasciculation similar thing?
No, they are tremors are different thing, fasciculations are different thing. Now, we come down. Tremors are actually oscillating movements, right? And fasciculations are due to lower motor neuron loss and postsynaptic membrane on the muscles develop hypersensitivity. Even with mechanical stimulation, it will start contracting. Tremors are very different. There may be tremors due to hyperadrenaline in the body, or there may be tremor due to basal ganglia dysfunction in Parkinsonism, or there may be tremors due to cerebral dysfunction. So tremors is a very different thing, right? Okay, let's come back. So what I'm talking about, now what about lower limb of this person? Motor loss in the lower limb. This lateral corticospinal pathway which was coming down has been, this was lateral corticospinal pathway which was coming from contralateral side. This has been damaged here. Is that right? And this is loss of upper motor neuron influencing the muscles going to the leg. Is that right? So what will happen to this? Number one, there will be, as compared to this, there will be slight loss of mass because lower motor neurons are action, they are in action and they are producing some trophic substances to maintain the mass of the muscle. So in lower motor neuron there is severe loss of muscle, here is mild loss of mass, but power is lost. So paralysis is there. Paralysis is there, but this paralysis is with hypertonia because reflexes here are over functioning. Alpha motor neuron as well as gamma motor neurons both are over firing due to loss of the moderation from the higher centers. So this will produce paralysis with hypertonia. Hypertonia. Tone is up, and this tone is very special type of hypertonia in which if there is initially to the passive movement, lower limb, to the passive movement initially there is severe resistance, and more you pull, more resistance and sudden loss of resistance. Then again let me tell you what kind of hypertonia is seen there. Can you come here? Okay, in this limb there was hypotonia. In hypotonia what happened, that you leave it relaxed. Hypotonia first, that there is no resistance to the passive movement, hypotonia. In hypertonia there is extra resistance, extraordinary resistance to the movement. This is hypertonia, extraordinary or excessive resistance to the passive movement of the limb, hypertonia. But if upper motor neurons are damaged, lower motor neuron system develops abnormalities in which hypertonia is strange, that when you pull it, initially it is very difficult to pull, excessive, then suddenly it gives way. This is called clasp knifing. When you try to open a knife, right, so some types of knife, yes, when you try to open the knife, initially it is difficult, then suddenly it opens. So we say this type of hypertonia in which there is initially excessive resistance to the passive movement followed by sudden loss of resistance, this type of hypertonia is called clasp knifing or spasticity spasticity. So what we say, that in lower limb syndrome there is flaccid paralysis. In lower limb, in upper motor neuron syndrome, here was lower motor neuron syndrome. Here the upper motor neuron, what kind of paralysis there? Spastic paralysis. If muscles lose the power and they are hypotonic, what is it? Lower motor neuron type of damage. But if muscles lose the power but they are hypertonic and spastic, it means this is upper motor neuron type of damage. So here there is loss of power with hypertonia and reflexes are increased, hyperreflexia, right? Hyperreflexia, and then there is positive Babinski sign. Babinski signs. Now I will not go into detail of Babinski sign because all these I have discussed in detail in the previous lecture on upper motor neuron and lower motor neuron and their liens. I will just tell you briefly, right? That in a patient where the lien is at cervical cord, upper limb shows the signs of lower motor neuron damage, and lower limb will show the signs of upper motor neuron damage. Am I clear? Lower limb will show, upper limb will show lower motor neuron damage, which is severe loss of mass, loss of power in specific muscles, loss of tone, loss of reflexes, and there may be fasciculations. Below the level of lesion, there is spastic paralysis. There may be mild loss of mass, but there is loss of power, especially in specific movements, and spasticity. We call it spastic paralysis with hyperreflexia or clonus, and with that Babinski upgoing, or we say dorsiflexion of the foot on stimulating the outer part of the foot sole. Right? Or there may be, we can say upgoing Babinski or positive Babinski or dorsiflexion of the foot on stimulation. Right? Any question up to this? So these are the motor findings ipsilaterally. Right? Contralaterally what happened? No major motor loss, power loss, but you remember there is anterior corticospinal tract. Let me show you. There are two types of corticospinal tract. Another diagram. Suppose this is a spinal cord. Here are lower motor neurons going out. Right? Now, upper motor neurons type, one I told you lateral corticospinal tract, where fibers came and then crossed on the lateral side, and while on going down, they stimulate them, control the lower motor neuron. In the same way, they will come over here and while going down. Now, these fibers are coming down in lateral funiculus, so they are called lateral corticospinal tract. But some of these fibers continue directly without crossing. These is and they are descending into interior. They are descending into interior funiculus, and from here at the level of lower motor neuron they cross. In the same way, this is also interior corticospinal tract, and this is coming in this area and then crosses to the opposite side. So we can say lateral corticospinal tracts cross at lower medulla. Anterior corticospinal tract come down, and where they are going to innervate or control the lower motor neuron at same spinal level they cross. Am I clear? Now imagine if lesion is here. If lesion is here. Now corticospinal tract which was going to innervate the ipsilateral muscles, these are lost. Right? And that will lead to upper motor neuron type of lesions in lower limb in my example. Clear? But this fiber, what was this? Anterior corticospinal. They are also damaged, but they were controlling contralateral lower limb. But they give a very minor control. So there may be minor loss of power in contralateral limb due to loss of anterior corticospinal tract. Am I clear? So these were the motor losses. Again, I will repeat the motor losses, the most important thing. I will make a test. Lesion is at C5 to T1 here on the right side. What kind of loss will be in upper limb, right side? Yes? Lower motor neuron type. And what kind of loss will be in the right leg? Upper motor neuron. Is that right? Now imagine if there is a lesion at the left side, what type of motor problem will be on the left upper limb? Lower motor neuron type. And what type of problem will be left leg upper motor neuron type? So you understand it? Any question? Then there's one more, just you have a question.
Sir, what happens to the vasomotor tone?
I'm going to talk about that. Yes.
So is there going to be any rigidity?
Yeah, of course there will be rigidity. Actually, rigidity means hypertonia. Hypertonia is of different type. There's lead pipe rigidity, there's clasp knife rigidity. Clasp knife rigidity is called spasticity. Right? For example, there's a disease called Parkinsonism. We develop rigidity in that also. But that rigidity is throughout the range of the movement. Such excessive resistance to the passive movement, which is throughout the range of the movement, is called lead pipe rigidity. But clasp knife rigidity is that rigidity initially is excessive, but then suddenly it disappears. That's clasp knifing. Am I clear? Okay, now we come back. So now autonomic fibers, right? Especially I should mention about the Horner syndrome, right? I will make from the side. Actually, here is your beautiful face. You do have a tongue and other things also, I hope. Okay, now here is hypothalamus with the pituitary system. Actually, from hypothalamus, autonomic fibers come down. I'm talking about sympathetic outflow. Polysynaptic pathways come down, and as they are going down, at T1 level, fibers start coming out. Now these fibers which are T1, T2 through L1 or L2, right? This is sympathetic outflow. Now, actually these fibers which are coming out at T1 section, right? These fibers which exit out, they go upward through the sympathetic chain and they terminate in superior cervical ganglion. From here, postganglionic fibers go upward and they supply to the face, skin. They also supply to the eye. They also supply to the dilator pupillae. They also supply the superior tarsal muscle. Is that right? Now what happens? If lesion is above the T1, for example here, then fiber T1 fiber of sympathetic outflow, they have lost the stimulation from upper level. Is that right? Now in my example I was telling that damage was at C5, 6, 7, 8, T1. So it means in my example the parasympathetic downflow, sympathetic fibers which are coming down, right, they have been interrupted due or crushed due to spinal cord hemisection. So T1 fibers outflow, sympathetic outflow on right side is dysfunctional, and that will lead to impairment of sympathetic supply to the face and oculi. Clinically it will manifest as loss of sympathetic supply to half of the head and neck, right, suppose right half, ipsilateral. That will produce a clinical situation called Horner syndrome. Already we have a big lecture on Horner syndrome which is recorded, but I will just mention briefly. Sympathetic fiber normally act as pupillodilator. So loss of sympathetic fibers will lead to pupilloconstriction due to loss of pupillodilator and pupil become miotic. So there is meiosis. Secondly, sympathetic fiber help the levator palpebris superioris to keep the upper lid elevated. And when sympathetic fibers are lost, upper lid, eyelid becomes slightly drooped. So we say there is partial ptosis. Along with that, these sympathetic fibers also supply the sweat glands on the half of the face. So sweating will be lost. There will be no sweating. That is called anhidrosis. And with that, vessels in this area, they may dilate and produce rubor or redness of face in this area. All this situation together is called Horner syndrome. So what is Horner syndrome? Horner syndrome is a condition when half of the face or sympathetic, oculosympathetic pathway or sympathetic fibers going to the half of the face, those sympathetic fibers have been dysfunctional, right? And that will lead clinical to what situation? That will lead to meiosis with partial ptosis, anhidrosis, and maybe vasodilation on the face, right? But if lesion is below the T1, then of course Horner syndrome will not be seen, right? So now we come in the end, again recap, what are the causes of Horner syndrome? No, what are the causes of Brown-Sequard syndrome? Hemisection of spinal cord. Remember, the clean-cut hemisection is clinically not seen commonly, but partial hemisection is seen commonly. So patient may have less commonly a classical complete Brown-Sequard syndrome, but more commonly patient have partial Brown-Sequard syndrome. Now in Brown-Sequard syndrome, what could be the causes? I told you most common is trauma, stab wound, bullet injury, dart, kicks, then there may be expanding tumors, there may be disc prolapse, or there may be cervical spondylosis, or there may be multiple sclerosis, or there may be myelitis, right? Yes, or septic emboli. Is that right? Now we come to again recap. Yes. We'll put 2 spinal cord levels and see what happens with the hemisection. Let's suppose hemisection is here. This part of spinal cord is lost. Now, dorsal column sensations which are going up, they are lost here. What will produce? Dorsal column sensation lost on ipsilaterally below the level of lesion and also at the level of the lesion. Then spinothalamic sensations, they were actually, yes, what is happening? They are going contralateral and they are also lost. So pain and temperature lost on contralateral side. Is that right? But because at here little bit angulation occur, due to that reason it is between 1 or 2 segments down. Then what happened? At the level of lesion, complete anesthesia, below the level of lesion, ipsilaterally dorsal column sensation lost, contralaterally pain and temperature, crude touch lost. Is that right? Any question up to this? And in this area, because lower motor neurons are itself damaged, so lower motor neuron type syndrome, and here lower motor neurons are functioning, but upper motor neurons which are coming here, they are lost. So upper motor neuron type syndrome is there, and then spinocerebellar damage that will lead to dystaxias. Any question? No question. Okay, now I will ask and you will tell me. We have a spinal cord here. We make half section. Now tell me at the level of lesion, which sensations are lost? All sensations lost. Right? Below the level of lesion ipsilaterally, dorsal column sensations. Below the level of lesion contralaterally, pain temperature, very good, pain temperature, crude touch. 1 or 2 segments below. Is that right? And due to damage to the posterior spinocerebellar tract, there is dystaxia in ipsilateral area below the level of lesion. And due to damage to ventral spinocerebellar tract, there is dystaxia to the contralateral area below the lesion and motor dysfunction. At the level of lesion, all the motor fibers which are going down, they are damaged. So what kind of damage is? Lower motor neuron damage. And below the level of lesion, lower motor neuron functional, upper motor neurons are damaged while they were passing through the lesion. So what kind of syndrome is there? Upper motor neuron type of syndrome is there. Class dismissed.